Skattebo, Cam Skattebo, New York Giants. What happened? Well, we're going to talk about that. He had an injury, and you guys can look up the video. We're not going to go and show you some gruesome pictures. It's probably a little blurred in the background. Maybe you'll see it somewhere up here. However, he reportedly had an open dislocation of his right ankle. Okay? Right ankle. I'm Doc Faisal, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports. I love talking about injuries. I take care of shoulder and knee injuries, and I operate and treat on them. And please consider this an educational, informative video only. Here we go. So, and if you look at the videos, you're welcome to do that if you got a good stomach for it, but you can see that the ankle was flailing and the end of his tibia was sticking like this. Shoe, leg. There was like a little bit of sock covering up that area. So we don't know all the details, but we know he underwent emergency surgery, and he posted on social media thanking people and saying he's doing well. Great to hear. That's not something you want to like get off the field and look down and see what's going on. Now, we're going to get into it a little bit. Dislocation. Why is it bad? Why is it not so bad? Open. What is open? Is it a fracture? What does it mean? And then how does it compare to a fracture dislocation or an open fracture dislocation? I mean, we could compare it. I mean, you can't really, apples, oranges, comparing fracture dislocation to an open dislocation, but we can. We'll go into it a little briefly, talking about the differences. So, I mean, if you land like this and you got your ankle flailing like that, you don't have your ankle sitting like this, okay? If that's gonna happen, which you saw, if you wanted to see on the video, that means your tibia, I know I can't break this, I've already tried, so we're not gonna do that, but this, I think I can pull it off, right.
That's what happened.
That's kind of what happened. Let's just reenact it. So mechanism of injury aside, but basically this is how his leg is sitting. So it's probably more like this. I mean, if it dislocated, so when it dislocates, what happens? So you've got your deltoid ligament. These are strong medial ligaments. Medial malleolus, which is actually part of the tibia. You have medial malleolus. You have the tibial plafond, which is the surface of the articular cartilage surface, which curves like this. And it essentially creates a little box like you see with the lateral malleolus, medial malleolus, tibial plafond. You have cartilage, 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 and you have this syndesmosis between, which has ligaments in the front, ligaments in the back, and we put it all together just like that in the OR, right? So, medial deltoid ligaments, anteromedial capsule, there's tendons coming across the front, tendons in the back, ligaments and tendons in the front. You've got your calcaneofibular ligament, and you've got anterior talofibular ligament and all your lateral complex. You've got a medial complex, you've got anteromedial, anterior capsule, you got posterior capsule. But what happened like this is that it was kind of hanging like this. So it's probably hanging off. You've got the tendons, you've got the ligaments. As far as we know, there was no nerve or vessel injury. So basically when it goes out, you've got your medial side and it's basically hanging like this. So you've got your Achilles tendon in the back, right? Your Achilles tendon, your neurovascular structures on the medial side. You have your tibialis posterior. You have your ligaments basically hanging like this, because it went out like that. So probably the anterolateral complex, or at least a majority of it, plus the posterior complex are okay, but the entire anterior and medial complex are likely gone. Now, as far as we know, there was no fracture. Was there cartilage damage? We don't know. Like when you have an injury, it shears off like that, okay? So you've got your medial lateral, and it kind of You land and it shears off like that, okay? Now, as far as we know, the fibula wasn't fractured, the medial malleolus wasn't fractured, it was just all ligamentous, so the capsule is gone and it shears. So that shearing could be an occult injury, which basically means that it may not present itself right away. There may not be fragments of cartilages broken, but there's bone bruises. And bone bruises, actually, we're more worried about the cartilage itself. We can see edema and essentially something lighting up within the bone marrow. And initially we just called it bone bruises, but later, in many years of research, we realized it's actually can have long-term complications and implications because of the cartilage injury. Think about the number of times body weight, the amount of forces going through that to cause this and that, right? So you got a box and it pops out. Well, the weakest link is in the front. You have the calcaneus and you've got a lot of good structures in the back, the Achilles. So it's anterior dislocation, subluxation, where the actual joint goes out the front, is more likely than if it were to go out the back. But it can happen. It can go straight out, front, back, and any mechanism rotation. I mean, if you start talking about motorcycle, car, vehicle, fall, major injuries like that, it can go out in any direction because the vectors of forces going through your body relative to gravity and the forces around you, whether it's a vehicle, ladder, you land at an angle, all of that comes into play. So, in this particular case, he had an isolated dislocation, but it was open. What does that mean? It means someone broke the skin. Now, I'm not saying someone went and took a knife to it. That's what we do as surgeons when we open a joint to look at it and repair things. But an open dislocation means that when it popped out, it basically ripped the skin. Okay, so that means you have a communication between outside the body and inside the body that's not a natural orifice. I mean, you've got a mouth. This skin is intact. There's no connection between outside the ankle and inside the ankle. So that's why it's an open dislocation. Now, you can have shear injuries and you can have terrible dislocations that remain closed, but this was open. So that means that's why it was a surgical emergency. Now, what else is a surgical emergency? Well, if you have a dislocation by itself is a surgical emergency. Now, it's not as urgent as an open dislocation, but it's still urgent because the longer it's exposed to skin. Now think about it. Dirt, grass, sweat, grime, crap. All around his sock, foot, shoe, ankle, right? And it rips through the skin. Luckily, it was covered by soft tissue, like his sock and clothing, so it's not completely exposed. We don't know. We don't know if the sock ripped. We don't know if there was grass or dirt inside the joint. I've seen it. I've seen the worst of the worst injuries at level 1 trauma facilities. And even I think one of my worst injuries I saw was a soccer player coming in and getting side tackled, having a fracture dislocation. And he had grass and dirt inside his bone and soft tissues when we opened it all up because of the cleat, right? So in this case, hoping that this is nowhere near as bad as that. And based on what we read, it's not. So great recovery, hoping for you really, really well. But there is going to be a time component. Now, what is involved in treating the open dislocation? Well, most important, you take it, you clean it out. So if it's dirty, you want to give it a good wash before you pop it back in. Now, sometimes you don't have a choice. It's out on the field, you put it back in, and then you have to deal with it later. You may not always have the right people at the right time in that situation, and sometimes it's the better thing to do. You know, all of a sudden you can't get a chopper, you can't get a car, you can't get a vehicle, and what are you going to do when you're out in the field? Whether it's military, whether it's hiking or emergency transport off a mountain, you have no idea. So you want to just line things up as best as you can and deal with everything later. Now, in an ideal situation, you're going to get him in the OR like that. Good snap. You're going to wash it out, put it back in, and then you're going to do a clean Debridement. Debridement, it's a fancy word we use. It's basically you're cleaning things out, you know? We're not using a pressure hose because you don't want to damage the cartilage. And actually one of my colleagues at McMaster sort of really developed a great understanding through his research on lavage and the pressure of the lavage and the water that you're hosing down. You know, do you use low pressure, high pressure? A lot of information out there and you can read about it. But the idea is you want to wash it, and you don't want to wash it too harsh, but you want to wash it cleanly. And the idea is you get all the exterior dirt, so you got to look in, you got to look inside the joint, make sure everything's clear, and you also look for fragments. Were there any cartilage or bone fragments? What else was injured? Because when it's open, you're going to see right in this space. And you can get impact fractures there. You can get your syndesmotic ligaments, your anterior talofibular. You won't necessarily look all the way in the back, but you will when it's out like that, because that's your best opportunity. So you might as well wash it all out and take a look right now. And what's the other thing? I always talk about neurovascular injuries. What's the other thing we worry about? Feel the pulses. You got to feel the pulses before, feel the pulses after, identify what nerve or vessel injury. Is he numb? Does he have any foot function? And you can still test foot function, right? Even if he's out, you say, can you wiggle your toes? Can you move it up? Can you move it down? Can you actually move your ankle at all? Because even when it's out, there is some mobility and you can feel the contraction of the muscle. So is there a nerve vessel injury? Identify whether there's any numbness, and then you treat it, you wash it out. And once you wash it out, you don't want to be doing it multiple times, right? You don't want to go pop it in. It's like, oh, I forgot to do this. Pop it out again. And then you put it in again. It's like, oh, I forgot to make sure there's no fragments in the back, and then pull it out again. One time, measure thrice, cut once, right? Well, same thing. You clean it out, you take a look, inspect it fully. You're probably pummeling it with 9 liters of saline. Okay, now 1 liter equals, 4 liters equals 1 gallon, just so you can convert and do the math yourself. But the idea is you wash it out, and that essentially the way we're trained is 9 liters of saline. Now, one could argue, is 3 liters enough for an ankle? Is 9 liters enough? Well, maybe you should do 12 because it was very, very dirty. And then you've got all the other things, the antibiotic prophylaxis, the tetanus, all of those things. Those are all the medical management of open injuries on the field in general. But we're focusing on the ankle. So we get it reduced. Obviously, the emergency part is just to reduce it and line it up. Do you do a repair of the ligaments and the capsule? Well, you can, but here's the challenge. Yeah, I heard someone say that. Sutures are foreign body. Suture material can be a harbor for infection. So just having an open dislocation means you don't want to do a full reconstruction with all the specialized tissues and implants we use, because there's always that risk of infection. You wash it out and maybe you come back, or you repair it, and you repair it with certain types of sutures which are less prone to infection. Now, we do have antibiotic-coated sutures nowadays. They're not always readily available. Not every facility has it, but there are those types of things you can consider. But what you don't want are braided sutures. Braided sutures are like rope-like sutures that are minuscule, even tiny, but they can harbor infection and bacteria. So you don't want to use that. So you use things like Proline and nylon, and you may just initially reduce it, line it up, close things up as best you can, and come back another day and assess his stability. So I'm not saying that's what happened. This is an educational video, and I want to hear your feedback, and there's a lot of different facets and factors involved in this particular case. I tried to cover the spectrum of it, and so that I'm not the treating surgeon in this particular injury. I'm going by the reports, and based on the type and mechanism of injury, I'm going over what are some of the challenges to consider. Now, I know you're wanting to ask, is this worse than Fred Warner? You can always compare. We had a closed fracture dislocation, which sounds like it was a pretty relatively bad fracture, is what I understand, but we don't have all the details. And then we have an open dislocation where maybe there was no cartilage damage, where there was no fracture. So which is better? Now, all things being equal, if it was a closed dislocation versus a fracture dislocation where the cartilage was damaged, which we don't know the details about, then the one with cartilage damage is always going to have, more likely than not, worse outcome, which means they're more likely than not to get arthritis earlier, post-traumatic arthropathy, post-traumatic arthritis, sooner than later. But again, we don't have a crystal ball. Whereas if you have a closed dislocation where you get the ligaments heal up fine, you don't need a second surgery, and it's closed, and there's no long-term sequelae of the cartilage, you're still at risk. Whoa, my voice went, you're still at risk of getting post-traumatic arthritis and arthropathy. But if you don't have a severe, significant amount of cartilage injury damage that's visible and noted, either initially or later, maybe on an MRI, then you're less likely to develop arthritis within 10 years. But if you have cartilage injury, you're more likely to develop arthritis within 10 years, maybe 20 years, okay? So that's the biggest difference. So all things being equal, closed dislocation to fracture, closed fracture dislocation, the fracture dislocation, more likely than not, is gonna have a worse outcome.
So even though he had to have emergency surgery, that's still potentially, without the opening, without the open fracture, open dislocation, is still a better long-term scenario.
They both said emergency.
But Warner didn't have emergency surgery. His surgery wasn't until like Wednesday.
Oh, yeah. That's right. Well, that's why, okay. So, Joey brought up a good point on a question, is that one is emergency surgery, one is not. Now, the reason for the emergency surgery is that in the open dislocation case, it was open to the skin, so you want to clean it before you reduce it. In the fracture dislocation, you can actually reduce it and line it up before you have to rush in to actually fix the fracture. And that's the other difference. Now, if you can't reduce a dislocation, it's still an emergency surgery. But the ER, and there's lots of good medications and drugs out there that physicians use in the ER, that anesthesiologists use, that allow the patient to relax, the muscles relax, and the patient still somewhat conscious. You don't have to take him into the operating room, because anything in the operating room is technically surgery, okay? So let's get that clear. If it's done in the ER, it's not surgery, okay? You're not in the operating room. That's the difference. So if you can line it up and reduce it under sedation, under conscious sedation, that's the term we use, you line it up, put an X-fix, and you wouldn't put an X-fix outside of the OR, but you put a cast, you put a splint, allowing for swelling. A cast obviously is not, when I refer to that, some of you are going to say, you can't put a cast on, he's going to get too much swelling and get compartment syndrome. Well, we're talking about a cast material. You're basically using something to line it up and keep it in place. And if the post-reduction x-rays, meaning the x-rays done after you line it up and make sure the joint is lined up, are okay, meaning the joint is aligned, then no matter what, you're like, oh, okay, we can let the swelling come down and go after it later. You don't need to do the emergency surgery. But if you have some displacement and you can't reduce it, then it does require urgent surgery. So, and the reason for the emergency was the open dislocation, for sure. Because if it was just a closed dislocation, they may have even tried that on the field just to line it up, or they did it immediately in the ER and gave him some sedation and popped it back in, and then made sure the x-rays were fine and it wouldn't have required emergency surgery. So the open aspect is the most important.
What's the pain level of an injury like this?
Pain is a good question. So the pain level of this injury varies. Again, I love to give my farmer example, because farmers are incredible patients. They show up with the worst of the worst injuries and joints. Like, you would find other people who are not farmers come in with slight issues. Whereas farmers will show up saying, I kind of broke this and mangled my hand, but I drove here to the ER because there's no way an ambulance would show up in time or ever be able to climb up the grade to my mountain house or whatever, wherever it is. If it were me, it's like 911, wait, get someone to show up. But also, like as a physician, you think too much. You want to take a chance. Like if I'm going to be driving, you know, with a mangled injury, bleeding everywhere with kids, it's like, hey, there's other issues involved. But I can tell you, my pain tolerance is probably more likely than not, lower than any farmer out there. They suffer through incredible pathology. It's amazing. So here's a shout out to all you farmers out there. Now, athletes, they have incredible pain tolerances, and everything varies. Is an individual in college who is doing computer science, is his or her pain tolerance going to be different from a super athlete versus a farmer versus a media guy? Probably the media guy is going to have the least lowest pain tolerance, right? Yeah. Crying like a baby, sobbing. Right? Sobbing, yeah. Hey, we've all been there. I think I gave the example. The injury that led to my startup was the soccer injury where I blew out my ACL, and I was screaming like a baby when I landed. I knew it was my ACL. I felt it tear, but I got off the field, and this was in Golden Gate Park. There's like a hill to get to your car, and I had a stick shift. So yeah, I did have to walk gingerly to my car and drive home with a stick and climb up 52 steps to my loft.
You didn't go to the hospital?
No. Because I knew it was in my ACL torn, so I showed up at Grand Rounds the next day hobbling, had a little instability, got my MRI. I was at Stanford, so it's like, you're...
You just fixed it yourself?
I didn't fix it myself, although I did have someone believe that I did. I said, oh yeah, I basically just numbed my legs and I did the surgery, the resident, and I kind of showed him how to do it. No, I didn't do that. I'm kidding. That would be unethical to operate on yourself.
That'd be super cool.
Yeah, it would be that De Niro moment, right? Have you seen there was the De Niro moment where he was a criminal. What was the movie? Great car scenes in that movie. But basically, he pulls out a bullet, stitches himself up, and says, "Okay, I'm gonna pass out now." Yeah, okay. No, I did not have my De Niro moment. Thank you for asking, though. Yeah. So, pain threshold is different for everyone. I think pain is very difficult to gauge, but these are going to be painful. I mean, you saw the reaction that Skattebo had. You saw the reaction that Fred Warren had, but once they're, sitting down and things aren't flopping around, you kind of have a bit of a smile, you wave. Fred Warner, I was shocked. He was waving and smiling. Like, did you see that? Like, man, that's incredible. And I mean, Skattebo obviously was still dislocated. He had it wrapped up and there was blood. So everyone has a different reaction. You can't judge people for their pain. That's a very difficult, situation. We try and gauge it 1 to 10, but hey, I haven't had kids. I'm never going to be able to have kids. So I don't know what pushing out a 10-pound baby feels like. That sounds painful.
It's a big baby.
It is a big baby. That's what I'm saying. There are 10-pound babies that are born out there in the world, and that's painful. So I think that with open fractures, amputations, IED blasts, like my God. Like here's a shout out to all you servicemen, military, and recruits out there. I worked at the VA when I was at Stanford. Like I saw the worst of the worst. I saw people with 90% burn injuries. I saw people with missing limbs because of amputations from IED blasts. That is painful. So you can't gauge your pain to someone else. You can only gauge it from your own experiences. But I've seen the worst of the worst. So that's why I can comfortably say everyone's pain is different. I mean, the most impressive was that 21-year-old kid, 23, 21-year-old kid with 90% burns on his body. He had the most incredible demeanor, and he was soft-spoken, and he was just happy to be alive. And there was only so much you can do when you have severe burns that affect your joints. And I was asked to see him about one of his joints, but every joint was stiff and sore and had issues because he had severe third-degree burns over 90% of his body. Here's a shout out to all you military and servicemen. Thank you for what you do.